Thank you very much for inviting me. As Dr. Soldado said, I'm Ferran Blasco. I'm working in the trauma unit in Barcelona, Hospital Vall d'Hebron, and this is part of my PhD. So the problem here is that pediatric forearm fractures can lead to malunion in up to 15% of cases. And the first question we can ask ourselves is, what is the clinically acceptable threshold for angular deformity in forearm fractures? In the current literature, has been shown that over 10 to 20 degrees of the diaphyseal malunion can lead to a significant loss of forearm rotation. The standard of care for this situation are nowadays corrective osteotomies. Here we present our case, which is a 13-year-old male who fell over outstretched arm and suffered a both bone forearm fracture. It was treated conservatively with a closure reduction and casting, and as we can see in the lateral X-ray, correction of deformity was achieved. But after 3 months, the patient suffered another trauma in the upper limb and sustained a both bones forearm fracture. As you can see in the X-ray, there is an angular deformity of 20 degrees in extension in midshaft of the radius. After closure reduction and casting, 12 degrees of extension deformity persisted in the midshaft of the radius. This patient, after 2.5 years, came to the clinics because he was suffering a symptomatic forearm rotation deficit. As you can see in the video, we have a full supination, but only about 10 degrees of pronation. So what are the treatment options in this situation? And to know the options, we need to know which is the main cause for the rotational deficit of the forearm. Is bone deformity, or it may be the interosseous membrane scarring. That's why we performed our study with the objective to investigate the role of interosseous membrane in the rotational deficit after midshaft radius extension deformity. We hypothesized that interosseous membrane release improved forearm rotation. And the methods were an in vitro biomechanical study to evaluate and compare the forearm rotation with intact interosseous membrane and after releasing the interosseous membrane in midshaft radius extension malunion model. Here we can see a picture of our model. We can see the radius already with the deformity, fixed with a prevent plate. We can see the interosseous membrane already released and the rotational reference system with key wires in the distal radius and ulna. Here we show our results. We used 10 specimens per group. We designed 2 groups, 10 and 20 degrees midshaft radius extension deformity. We can see that the rotation in the intact forearm was around 160 degrees. The rotation after the deformity was decreased significantly, and interestingly, we found that really the interosseous membrane release we got a significant increase in forearm rotation. As we can see, much more in the 20 degrees midshaft radius extension deformity. In terms of discussion for the in vitro part of the study, we found that intact forearm rotation and the decrease in the forearm rotation following the bone angulation that we got was similar to previously reported studies. No previous interosseous membrane release in forearm malunion cadaver model has been reported nowadays. There is only one single clinical study performed by Nagy et al. In 2008, in which they were treating malunited forearm fractures. They first got the corrective osteotomies, and afterwards, if the rotation of the forearm was not enough, they were performing the interosseous membrane release. And they didn't find any complications in terms of pain, synostosis, or instability of the distal radioulnar joint. So we are back in our case. We remember the important forearm rotation deficit pre-operatively, and we performed an isolated interosseous membrane release through a volar approach. Here we can see the vast increase in the pronation and the stability of the distal radioulnar joint. Here we can see that we increased the rotation from 10 degrees of pronation to 90 degrees of pronation. Here we can see the small incision we did for this operation, and those are the clinical pictures after more than 2 years after the procedure. As we can see, the supination is full supination, and pronation, there was a small limitation, 60 degrees of pronation. We didn't find any weakness, instability, synostosis, or pain in the distal radioulnar joint. And here we show the X-rays, where we can see that there is no synostosis, and the deformity of the bone is present. Here we show our small case series, where we can see that the preoperative pronation in all cases with extension deformity of the radius was 0 or 10 degrees, and how it increased after the interosseous membrane release. There was a case, a really severe case, where we performed the osteotomy and then the interosseous membrane release, and was the one who got the worst results in the follow-up. In terms of discussion, isolated interosseous membrane release without the need for bone osteotomy and plate fixation may be enough to obtain a functional forearm rotation in selected cases. Interosseous membrane release with intact bony anatomy would not result in any axial or forearm instability as far as bony structures are present. There is a logical concern about the progressive development of distal radioulnar joint instability due to the increase of tension in those ligaments. Here we present a proposed algorithm for those cases. These malunited forearm fractures, we have to check the distal radioulnar joint. If this is stable, you can perform safely the isolated interosseous membrane release. If the distal radioulnar joint is unstable, you may go first for the corrective osteotomy, so the orientation of the distal radius and ulna is corrected, and then if the rotation is not enough, you may go for the interosseous membrane release. So in conclusion, the interosseous membrane release could have a role in the therapeutic arsenal for the treatment of malunion in extension of mid-shaft radius fractures. We are ongoing additional studies to simulate other malunion patterns. We are almost done with the mid-shaft radius flexion malunion, and we found, as preliminary results, that isolated interosseous membrane release doesn't increase forearm rotation. And we are starting the cadaveric model for proximal third radius malunion. Thank you very much.
Wonderful, Ferran, wonderful. Thank you.
Thank you.
Ferran, one question. In those 3 cases with mid-shaft extension radius malunion, which was the angulation?
In those clinical cases, so the one we presented here, it was not that much deformity. It was just like about 12 degrees, but they are all over 10 degrees. But there is one of those cases got a couple of operations and reoperations due to non-union before. So the scarring of the interosseous membrane may be the main problem in those cases. They are all kind of end stage forearm fractures with a lot of rigidity. They are not kind of straightforward cases. They are all
because there must be a number after which the interosseous membrane has no sense, no? Because imagine 30 degrees, no, of the diaphysis, of angulation of the diaphysis, but all of them were like the less than 20, right?
Yes.
Less than 20. Okay. Any comment from
even if you go for 30 degrees, for example, I think it would make sense to first address the bony part and then see if you get enough forearm rotation. And if there is not enough forearm rotation after the osteotomies, you may think about releasing the interosseous membrane.
Ferran, in the cadaver, we choose 10 and 20, right?
Yes.
And why not 30? I don't remember, because there was like a bony impeachment, no? Was it or not?
Yes, because if you go for a more severe deformity, I think it doesn't make sense to go as for the isolated interosseous membrane release. I think it may be as an adjunct treatment, the interosseous membrane release.
Yeah.
I don't think it makes sense because the distal joint, I don't think it will work with this degree of deformity.
Okay, comments from the board or from the from every participant, please. Message. Why it's called? Yeah. There is a very good question. So it should be a supination. Sorry. It's a question for you. What is it called? Extension malunion.
So because in the cadaveric model, we went for we made a model for the extension deformity, also for the flexion. We are ongoing for the flexion deformity. So it's important because you have to make sure that you have to understand the deformity of the bone before going for this treatment. You need to know if it's an extension or flexion. There is also one of the limitations of this in vitro study is that we didn't simulate any angular deformity, any rotational deformity, which is also a problem of those fractures. So this is the first step of a kind of a large way of thinking about the forearm malunion treatment. This is not the end of the study. You know what I mean? ¿Cuánta longitud de membrana se libera? So to make it simple and easy to reproducible, we did whole. We released the whole membrane. The whole membrane. We only left the distal radial joint and the proximal. We didn't. We go for the whole interosseous membrane. That's a reasonable question, and it could make sense in the future, depending on the location of the deformity. Go for maybe you don't need to go for the whole interosseous membrane release.
Ferran, one question, Ferran. Is there any model which tells you how much bone supination you have depending on how much extension you have? Extension.
I didn't find. In fact, I understood that I know that extension deformity is normally because of a supination moment when you have the trauma. So when you are reducing the fracture with a closed technique, you have to reduce it in pronation normally. But I didn't find any model that was showing it in any in vitro study or clinical. I didn't find it, but that's what makes what I always understood from forearm fractures.
Okay. Scott, Dan, are you aware or any study doing this correlation between extension and supination in supination deformities in the forearm supination malunion?
I'm unaware. Paco, I'm still struggling with the concept. I know I asked a question about extension. Extension means what? We would say that's an apex volar malunion.
Yes.
It would be apex volar, yes.
Okay.
So you say apex volar malunion, Scott?
That's how we define it. We don't define it as extension.
It's common in the literature to find it as volar or dorsal apex deformity, yes, but we called it extension.
Yeah. And Paco, we certainly see the same thing, and I know we're talking about today in BP or sometimes in CP, where the forearm gets stuck in supination, and you release the membrane and you gain pronation. But that's a different entity than what you guys are talking about. What's interesting to me is it's a acute phenomenon. I've always wondered whether the interosseous membrane is scarred over time, or does it just happen? If you're in your model, it's acute.
Acute.
Yeah, it's
Right.
interesting.
I mean, the model, in fact, is tensioned more than scarred because it's cadaveric. So there is, in the model, there is no scar, there is just tension more than scarring. Scarring, it would be what we understand that happens in the patients, but the model is the tension that got with the deformity, I would say.
Yes, you, Scott, Dan Soldado, in one of his papers, hypothesized that over time you can have a scar. So you have to correct the deformity before 1 year or 6 months, right? So you were thinking also about the interosseous membrane role in the malunion, right?
For sure, actually, for sure. But that's what's so fascinating about this is an acute phenomenon. I mean, there's also an interesting question about, we know that the interosseous membrane gets tight in supination. So how does increasing or releasing the membrane give you increased pronation? That's the question.
I would say that when I was thinking about the discussion, I searched a lot of papers about when is the interosseous membrane more tension, and I found that not only in supination, some papers were saying that was in neutral or also in pronation. So I don't think this is as established as it would sound here in the question. That would be my.
Let me make Dan a co-host. He's asking me to, because okay, co-host.
I think
okay,
I'm unmuted.
You can unmute
already.
you.
Yeah.
Dan, you can unmute you.
No, I'm good. Can you hear me?
Okay.
Yeah. So the comment that I had made before is based on a Tar, I think it's Tar, Garfinkel, and Sarmiento, and they did osteotomies. Yeah, I'm sure you know this paper.
Yeah, sure. This is yeah. We yes.
Yeah, so and there's another study where they look at Montasias, and after a year, I don't think it's the same group, but there's another study where they looked at Montasias, and after a year, corrective osteotomies did not really help. But I think one thing we've discovered, I think, is through using computer modeled osteotomies, is that I think that's not true. I think the reason that you have a year to fix these fractures by eye is because after a year, you can't tell what the deformity is because of remodeling. But I think that, I think this lends further evidence that maybe the IOM just stays as it is. And it's not the IOM that causes the problem long-term. It's just this sort of bony remodeling that really changes things and makes it more difficult. Because we've done corrective osteotomies now years out and have had no issues with forearm rotation. Well, that's not true. We've had some residual forearm rotation loss, but we've certainly not had any issues restoring DRUJ or PRUJ stability. As long as you get the bone, well, more DRUJ stability if you restore the bony anatomy. PRUJ is still more difficult. You agree, Scott? Anything? Oh, you're muted.
Scott.
Okay, I'm unmuted. No, I totally agree. I think we've learned a lot from this 3D modeling about bony correction. That's what's so interesting to me, that there's an acute loss of rotation secondary to the bone. It's kind of all making sense if you think about it. But I agree with Dan 100%. After a year, especially in children, you can't tell where the bone was broken or the angular deformity or how much remodeling has occurred. And I think that's why we've always had the tenet that after a year you cannot gain rotation. But I don't think that's true anymore. I agree.
So Scott, in the flexion model, apex dorsal, IOM release doesn't increase the rotation, but in the proximal third of the radius, it release also increase the supination. We want to play with everything: radius, ulna, flexion, extension, rotation. So we will discover in the future.
Yeah. I mean, Paco, the measurements we talk about in terms of what's acceptable and what's not acceptable are poorly defined. And I think what you're trying to do is define those acceptable versus unacceptable. A lot of times Dan and I will look at an X-ray and just go, that's not going to work. It needs to be reduced. But there's no absolute number that we rely upon other than the crossover sign. So if you look at the X-ray that's up there, that middle X-ray on the right, so there's 1, 2, 3, 4, the fifth X-ray from left to right, that the radius that crosses over the ulna there on that lateral X-ray, that's a problem.
Yeah, there are many factors like age, level, ulna, and radius, rotation that you are not able to evaluate. So many factors, yes.
Yeah, but I do think Scott's right that the crossover sign, regardless of age, has been very reliable. When I've taken those kids to the OR, they all have loss of form rotation, one way or the other.
Yeah. So when you say once they're asleep and you examine them, that crossover sign, that's Chad Price's crossover sign. It is reliable. They will not be able to rotate. And when you lessen or when you correct that crossover, they will gain rotation immediately.
So sorry, I didn't understand. Can you repeat the
Dan, you want to give it a go?
Yeah, sure. If you look at that X-ray that Scott pointed out, you can see how the radius goes up over the ulna and then back around. So it crosses over. And once it crosses over the ulna, and this happens really on proximal third radius fractures, this crossover. Once you get that, it's deceptively large amount of angulation. And we have found universally that when we take these kids to the OR, they have loss of rotation. And we've also been very happy with the outcomes so far and we usually plate these because they're hard to really hold with a rod.
Okay.
Yep.
Thank you. So should we move to the next talk? Oh, there are some comments here. So Praveen asked about the cutoff to decide to go. This is theoretical, but maybe 20, because in the cadaver at 30 there was like
impeachment.
Bone impeachment, right?
I don't think it doesn't make sense to make isolated interosseous membrane release if the deformity is over 20 degrees. I don't think so.
Very good. Thank you, Scott, for sharing the reference. And then they asked how much, what length of the interosseous membrane do you release? You answered to that, right?
Yeah, I already answered, yes.
Okay, so let's go.
Sorry, it's missing one question about Campbell 1 that says the majority of the interosseous membrane is tight in supination. The release here seems.
Yes. I answered that. I don't think this is as certain as it was. It is right in here because there is literature available that says that it's also in neutral position and also in slight pronation. I don't know what the panel says, but that's what what the literature says about the tension of the interosseous membrane.
Yes, I checked some specimens, and there are parts of the interosseous membrane that gets tied in supination and parts that get tied into pronation. So, which is what you are saying. Okay, can you stop sharing?
Yes.
Ferran?